5, 4, 3, 2, 1, live ma'am.
So good evening, everybody. Uh, Today we have a webinar on practical tips for glaucoma. So today we'll be discussing, very practical things which are important in medical management, which I'll be taking. We have Dr. Sachin Dharwadkar who is going to speak about OCT and its practical aspects, and then we have Dr. Deepak Edward with us, who is an esteemed panelist from US, from Chicago, and he would be joining us in a while. And so just be with us throughout the time, and and enjoy this presentation, and I'm sure that you will be learning a lot and getting some practical tips out of this. So I would just begin with my presentation, that is 7 points to remember for medical management of glaucoma. So these are some practical tips or practical points that we see in our day-to-day practice. I'll be just sharing my screen now. Yeah. So is that visible now? Am I audible? Is this visible? My slide is visible to all?
Yes.
Okay, fine. Okay, so we'll start with today's first topic, that is 7 points to remember for medical management of glaucoma. I am Dr. Anupam Deshpande, and I am a glaucoma consultant at Aditya Jyot Eye Hospital, Mumbai, and also I have National Eye Center in Thane. So to begin with, what is the goal of our medical management? Preservation of visual function, maintaining a good quality of life, lowering IOP to a level at which further damage is minimal, and medications with least side effects and which should be affordable to the people, and to educate patient and his family. So we keep all these points in mind before starting our medical management. So the prevalence of development of open angle glaucoma, that is natural history, is that this is a normal disc with no perimetric defects. This are glaucoma suspects where the disc may be suspicious but no defect, and this is early glaucoma, moderate glaucoma, and advanced glaucoma. So it's easy to detect somewhere here, but our goal is to detect these patients here, which are glaucoma suspects, which would be the best thing to happen, or sometimes in early glaucoma, where there is a mild defect and you still catch them earlier and treat them. So basically, you need to catch them here at these points and treat them so that there is no progression and their visual acuity and the visual field of vision remains stable. So because of this, patient evaluation is my first point. So before you start any treatment, you have to evaluate the patient to know whether he is glaucomatous or not, and to catch them early is the at the right time to start your medical therapy. So history with complaints is important. We'll not go into details of all the points. Visual acuity is basic. Refraction, tonometry has to be an applanation tonometry, which is the gold standard. Pachymetry, to know whether the corneas are thin or thick. Slit lamp examination again is a basic kind of examination. You need to note everything about the anterior segment. Gonioscopy is very important in the glaucoma diagnosis as well as for further evaluations. So your examination is not complete without a proper good gonioscopy. Retinal examination to rule out any other cause. Optic nerve evaluation is very important, especially it has to be done by a slit lamp biomicroscopy, that is with the help of a 78D or a 90D. Why? Because it will give you a 3D image, and it will give you a 3D image of the disc, which will tell you all the subtle points. If you are doing a monoocular ophthalmoscopy, the problem with that is that you don't get a 3D vision and you might miss those subtle points in the disc. So do it with a 78D or 90D, which is desirable. Perimetry again is basic and gold standard test for glaucoma. Either you can do a 24-2 or a 30-2 test. we prefer a 24-2 test because basically it is more reproducible and more repeatable, and also takes little less time. OCT, HRT, and GDX are there. Nowadays, HRT and GDX are not that commonly performed, but OCT is definitely there and is commonly performed. So we do perimetry and OCT in all our glaucoma patients initially, and also for the follow-ups. Now, documentation of all these things is very important because it's a long-term therapy, it's a lifelong therapy, and you need to do a lifelong follow-up of these patients. So you need all those documents with you, and also for medical legal purposes, it is important. Second point would be coming to the treatment plan. So you should have a proper treatment plan in mind, and this will depend upon type of glaucoma, the stage of glaucoma, whether it is mild, moderate, or severe, the life expectancy of the patient. If the patient is younger, your target pressures probably would be lower and you would treat them more aggressively because you want to preserve the vision for a longer period of time. If it's a older patients with a lot of comorbidities, you might just relax and the target pressure might be little higher, and treat them not that aggressively. Lifestyle of the patient, if the patient is traveling a lot, so all those minor things have to be taken into mind so that he can put his medications properly. Any comorbidities patient is having, so that you can avoid certain kind of drops like beta blockers in case of heart problems. So all these things you have to take into consideration. And of course, like countries in India, affordability is very important. So that also is an important factor when you are prescribing medications. Now, target IOP. So how to set up and target IOP? So you know that there are various stages of glaucoma that we have seen before. Mild, moderate, and severe is basically 3 stages which we can divide these patients into. And AAO has some guidelines for target IOP. Now, glaucoma patients with mild damage, there can be a reduction of about 20 to 30%. Mild damage means there are optic disc changes, but probably no visual field loss in the beginning. So about 20 to 30% reduction is desirable in these patients. Glaucoma patients with advanced damage, reduction of about 40% or more from the baseline. If it's a normal tension glaucoma, then reduction of about 30% from the baseline. Ocular hypertension, reduction of about 20% from the baseline. Open angle glaucomas in mid to high 20s, having pressure in mid to high 20s, you might keep a range of about 14 to 18 for these kinds of patients. In case of advanced glaucomas, 15 or less would be a good IOP for them. And if you have an ocular hypertension whose pressures are high, like maybe more than 30 millimeters, then get down that target IOP to about 20 or little less. So these are very general guidelines, and these are the things you might remember while seeking your target IOP. But the important point is that this target IOP needs to be reassessed and modified, because it's not like a general thing for all the patients. It cannot fit, one pressure cannot fit all. And that is why you need to reassess them with your serial perimetries all the time, and then see whether there is progression or no progression. If there is no progression, means you are on the right track. If you feel that there are changes happening in spite of your achieving your target pressure, which means that your target pressure has to be lower, and so it has to be modified. So treatment initiation. Now we have a lot of medications which are available, different group of medications like prostaglandins, beta blockers, alpha agonists. So how to choose from these medications? So how to choose is the key for this is how they act. So prostaglandin analogs, about 18 to 31% reduction during the daytime, and they also have good effect at night time. Now I am saying these medications effective, it is not just pressure lowering effect, but you have to consider their pressure lowering effect even at the night time, and we'll see why that is also important. Beta blockers, 20 to 27% reduction during the daytime, but has little or no effect at night. Alpha agonist is about 12 to 29%, but little or no effect at night. Carbonic anhydrase inhibitors has 13 to 22% lowering effect during the daytime, and about moderate efficacy during the nighttime also. So these points are very important. There are a lot of landmark studies which have been done in glaucoma, and the conclusions of all those studies are, basically what they say is patients treated early and aggressively had better visual outcomes. Lower IOP modifies the other variables we cannot change, because we know that pressure is the only modifiable or variable factor that we have in our hands. Rest, we cannot change anything else. Hello. IOP lowering offers the best neuroprotection. So how to start a medical therapy? So start with one drug at a time. If you are starting with two or more two drugs, then the problem would be that you don't know what is the pressure lowering effect of what drug. So always start with one drug at a time. Only in cases where the pressures are very high, and you need to bring them down, that time you can start with multiple drugs and oral medications together. In this, if the pressures are very high, then you can have a step down approach. But basically, for all the other open angle glaucomas, you should have a step up approach. So always start with one drug. One eye therapeutic trial may be desirable. That is, you start medication in one eye and then see how is the pressure lowering effect comparing to the other eye. But usually this will take more number of follow-ups. Probably that would not be possible all the time. So it is okay that you start medications in both the eyes together. Drug with at least 20% lowering effect has to be your first line therapy. So you have to choose the drug accordingly. Also, you have to consider other factors that we have discussed before, like comorbidities and all the things before you choose the drug. And of course, affordability would also be a point that you would think about. And since it's a long-term therapy, so preservative-free or a BAK-free medication would be preferred. Now, whether to switch or add a medication. So IOP reduction, if you start the medication and you're getting IOP reduction, which is less than 20%. So remember that your first medication should be at least 20% reduction. So if that has not been achieved, you must switch the medication to something else. If there are severe side effects, then also you need to switch the medication. If you have started medication and you have achieved that 20% or more reduction in the IOP, that means your drug is working well, but still your target IOP is not achieved. So in that case, you need to add a drug to your basic medication. The time interval between the two drops is important. So when you are adding medications, maybe 2 or 3 medications patient is using, then a proper interval has to be there between the two medications. So don't put all the medications together at one time. That would not work well. You need not just a pressure drop, but a 24-hour IOP control. And we'll see why that is more important. Switching intra-class medications is not effective. That is, if you are putting dorzolamide and that is not working well, then there is no point in switching to brinzolamide, which is of same group. So you have to switch to something else. But in case of prostaglandins, if you are using say latanoprost and if it is not working that well, you might try travoprost or bimatoprost, because only in prostaglandins you are allowed to switch intra-class. So sometimes they may work well if one doesn't work well. So combination therapy. So combination therapy is basically two medications in one bottle. What is the advantage? There is decreased number of drops and preservatives. So there is improved compliance because you have to put less number of drops at less amount of time. It's convenient to the patient. It is cost saving sometimes. And prostaglandins and beta blockers are one of the best combinations that you can have. So these are most potent combinations available. So combination therapy, basically two medications should have an additive effect on them. That is, the effect depends on their mechanism, and they should have an additive effect. So timolol basically mixes with all the other medications, and also you have a combination of brimonidine and brinzolamide. How frequently should be the follow-up? So that will depend upon the severity of the disease. So if first visit after starting the medication should be at least 1 week afterwards. So say ranging from 1 week to 1 month. If the pressures are not very high, you can safely call the patients after 1 to 2 weeks to judge the pressure lowering effect of that drug. Only if it's the pressures are very, very high and you want to see their effects with oral medications also, then you might call them more, little earlier. But first visit 1 week to 1 month, ranging from 2 to 3 weeks would be something ideal to know the effect of that medication. And in first year, about 3 to 4 monthly follow-ups has to be there to establish progression. Now, in the first year of the diagnosis, at least 3 perimetry reports have to be done to detect for progression. So in first year, it has to be 3 perimetries. In the second year, at least 2 perimetries. And in the third year, at least 1 perimetry or 2 perimetries. So over a period of 3 years, you need to do at least 5 to 6 perimetry reports, which will show you or tell you about the progression. Then suspects and stable patients, you can call them every 6 months or 4 to 6 months, but you have to be sure that they are stable with the follow-ups that we have suggested before. And IOP checks has to be done at various times of the day. Now this is important. Now why this is important, that we'll see. So there is a concept of 24-hour IOP control. So IOP control doesn't mean that pressure lowering from the baseline, but it has to be a 24-hour IOP control. And why that is important, that we'll see. There are a lot of studies which have been done. So this study shows that any single, that was done by Josh Jonas et al. Any single intraocular pressure measurement taken between 7 a.m. to 9 p.m. has higher than 75% chance to miss that high point or diurnal curve. So this is the office time. So most of the times probably we are missing that higher diurnal curve. So at least if we are taking pressures at different times of the day, probably we'll get that high. There are more chances of getting that maximal value of the pressure. So this is the diurnal variation you are seeing. This is a glaucoma patient, and this is a normal patient. This is the daytime pressure, this is the nighttime pressure, and so you can see this diurnal variation. And this is in sitting position, and this is in supine position. So even while you are sitting or supine, your pressures are going to go high a little bit more. So what happens at night? So possible nocturnal occurrences, there is an elevated intraocular pressure. This may be because of diminished outflow facility, because of hormonal changes, and because of direct pressure on the globe. And the second thing what happens is there is diminished ocular perfusion pressure. So in case of compromised optic nerves, now these factors are going to damage that optic nerve, which are optic nerves which are susceptible may add these things. These factors may add to their damage. So that is why even at night time your pressures have to be under control. So these studies show that that there are increased diurnal variability in the intraocular pressure is positively correlated with the progression of the visual fields. Another important study by Asrani et al. Large diurnal fluctuations in the intraocular pressure are an independent risk factor in the patients with glaucoma. So this was an interesting study which was done. This was a very long-term study. Two group of patients, one with glaucoma, both of them with glaucoma, and both of them apparently had controlled glaucoma. But one group of patients progressing towards blindness, while the other group of patients having not progressing much. So when they saw their mean IOP was similar in both the groups, so mean IOP was same, but then why did one group progress towards blindness? And the reason was that the variability of each patient IOP over the years was significantly higher. So the patients who had significantly higher variation in their IOP progressed towards blindness, while those who had stable pressures did not progress. So definitely these glaucoma fluctuations are a higher risk factor for progression. And for achieving this 24-hour IOP control, prostaglandins are one of the best medications which are available today. So here you will see, this graph is uncontrolled glaucoma without any medication. This may be with timolol, but here there are large fluctuations. Here the fluctuations are not much controlled by timolol also, although you might get a good pressure lowering effect. This is the normal pressure IOP fluctuation or diurnal variation, and these are with prostaglandins. So this is a study which shows effect of timolol, latanoprost, and dorzolamide on the circadian IOP in glaucoma or ocular hypotension. So this is the glaucoma patient having normal IOP, having glaucoma diurnal IOP variation, which is not on medication. So you'll see a large, higher IOP and large diurnal variations. Here we have timolol. Timolol has got good pressure lowering effect, but unfortunately at night, if you see, it does not work so well at night. This is dorzolamide. It has got a pressure lowering effect, not as good as timolol, but it has better IOP control during the night time than as compared to timolol. And this is latanoprost. Latanoprost has a good pressure lowering effect, not only during the daytime, but throughout the day and at the night time also. So for 24-hour IOP control, prostaglandin are one of the best medications that we can be using. So also, last but not the least, my seventh point is patient education. So non-compliance is one of the major problem for preventing blindness. If the patient is, you have prescribed all the medications, but if the patient is not using it regularly, then it's of no use. And major problem for this is one of the major problems. How do we address it? Because why this is important, because there are no symptoms, the consequences are delayed. That is why patient thinks that probably nothing is going wrong with his eyes, and even if he's putting medications, probably he does not feel any difference. So probably there is lack of motivation because of that, and sometimes cost also may be prohibitive. So patient education would also be an important point. So making understand the disease to the patient and also to his relatives, also to the relatives, because they are the ones who have to encourage him to take regular medications. This can be done with the help of booklets or videos. Discussion, giving more chair time to the patient and his relatives, at least initially, is also very important. So spend that extra time with the patients initially, so that you make them understand about the disease and the importance of the medication. Proper installation of drops is also important, especially if the patient is having multiple drops. The way the drop has to be put or instilled has to be shown to him initially, because it has a lot of studies which show that even educated patients might be doing a lot of mistakes in putting medication. So teach them how to instill a drop properly in the eye. Spacing of the drop. So if you are on 2 or more medications, the spacing has to be there properly. So say if you are putting timolol at 7 in the morning or 8 in the morning, your dorzolamide or your brimolol, your brimonidine would be probably an hour later. So 3 times brimonidine would be, say, 828 or 939 or something like that, where you have a good spacing of the medications. So you get a good IOP control throughout the day and also throughout the night. So you have to space them properly to get maximum benefit out of the same medication. So in conclusion, we have all these 7 points which are important: patient evaluation with proper documentation, a proper treatment plan in place before you start that treatment, set a target IOP, do a good treatment initiation with the medications that we have discussed before. Prostaglandins probably are the drug of choice, the first line therapy. Combination therapy, of course, would be important if patient is on multiple medications. Concept of 24-hour IOP control is very important. So this is one of the most important points. Just don't think about lowering the IOP, but to have a good 24-hour IOP control is very important. And last but not the least, patient education. So please remember all those points when you are treating a glaucoma patient. And early diagnosis and treatment is the key here for having a good outcome for the patient. Thank you. Yeah. So what the next presentation will be with Dr. Sachin. Dr. Sachin Dharwadkar is Director of Glaucoma Services at Aditya Chotai Hospital, and he would be talking about OCT and its uses in glaucoma. So I welcome Dr. Deepak Edward. Welcome, sir.
Good morning.
Hi.
Good afternoon to you.
Yeah.
Deepak, good morning. Welcome.
Oh,
Deepak.
thank you.
And thanks for the support. And I wanted to remind here to Sachin and Dr. Anupam that Deepak is our visiting faculty, which he has signed up when he was in Saudi, and he still continues. He's our honorary visiting professor.
Well, absolutely. Thank you.
Okay. Okay, Sachin. Sorry for interrupting, Sachin.
Okay, so after that very nice and crisp talk by Dr. Anupam, I would just highlight a few points that we should keep in mind while using the OCT for the management of glaucoma. This will be restricted only to the disc, macula, and RNFL. First of all, I would like to welcome Dr. Deepak Edward. It is a pleasure having him here, and we eagerly await his talk that is to come after me. So without much ado, I start my presentation. I'm just sharing my screen. Is the screen seen?
Yes, yes.
Okay, so we are discussing about the role of OCT in the management of glaucoma. There are certain things that we should always remember about the basics of using OCT in glaucoma care. One is that it is usable for assessment. The technique should be fast, easy to use, accurate, repeatable in its measurements, and capable of assessing progression. So unless all these criteria are satisfied, any machine of OCT cannot be used for glaucoma assessment. It should be minimally user skill dependent and basically heavily automated with the right hardware and the software. And progression assessment being the cornerstone, this feature is a must. So if the machine does not have the software and the hardware for progression assessment, it cannot be used for glaucoma care. Now, as we know, vascular insights that are associated with glaucoma or are independent, they behave very differently on imaging as compared to conventional glaucoma. So, truly speaking, glaucoma can be classified. The only open angle glaucoma and chronic angle closure can classically be followed up with the conventional knowledge of the OCT. The knowledge of OCT angiography has also told us that there are certain things which occur differently in other types of pathologies, like associated high pressure related ischemic damage to the ganglion cells, and that's why we get different patterns of nerve fiber loss there, which you should keep in mind. So having said that, we have to remember that when we use OCTs, all the machines and their hardware are not the same. We have various studies that are being done, and a very few machines have the test, retest, reproducibility, and the intra and inter-test variability, which is good enough to merit its use in glaucoma treatment. So it should be remembered. These figures show you the different the variability in the measurements of different machines, as well as the relative resolution of different machines that are available. Scan qualities of machines, the kind of data that they give out, as well as the quality of the images, all differ vastly across the board. And before making a judicious choice of the machine to use, you should be well aware of all these faculties and then make the right choice to use for glaucoma assessment. So this RNFL or macula, which one to follow? Now there are a number of studies that have come and so much of literature that it confuses the reader, which is the best parameter to follow. Although all this is basically too much of noise and too less of information, the basic thing is ganglion cell to the optic disc. That is the nerve, that is the axon. It is just one neuron. So seeing different parts of the neuron and judging which is the best to give you an answer is maybe technically a bit inaccurate. So ideally what I would suggest is you look at the whole neuron, which is always more meaningful. Now this is the conventional report of the OCT that we used to get before the ganglion cell segmentation used to take place. Now if you see, this is a slight bit of incomplete information. Now add to this image where you have the imaging of the disc analysis, RNFL analysis, and a macula analysis. All these three, you see the entire strip of the neuron ending in the optic nerve head, and this makes the entire analysis more meaningful. So any machine that is not giving you this particular component is not going to be giving you the correct amount of information to make the right decision in glaucoma treatment. Now looking at another example of the same is here. Here if you see, had you seen only the disc and the nerve fiber layer, you have everything in the green, although you had suspected something because of thinning of the inferotemporal quadrant, but on imaging, everything would have been normal. When you see the macula, you definitely make out the notch at the donut, and that's why you can definitely say that what you saw clinically is now reversely correlating to the localized thinning of the NFL as well as the localized thinning on the disc margin. So this will definitely give us a better clinical correlation by looking at the entire length of the neuron of what is right and what is wrong. Now, requirements of an ideal OCT for glaucoma progression. Now, there is very important things that are required if you want to use the machine for progression assessment. One is that the machine should have a very fast tracking system. It should have exact reorientation system to take each and every scan at the same position, as well as it should have an auto rescan placement facility. So all these things are absolutely required, like DMO and vessel track, auto centration and auto e-scan. Otherwise, it is very, very difficult to measure the same point over a period of time and get an ideal idea of progression in glaucoma. Now, that's why the next question, which machine and why? So you need a machine that is fast, having a tracking system. Segmentation of macula is essential. You may not have an independent segmentation of the ganglion cell layer, but you should have an accurate segmentation of the macula, which can be represented usually in a single chart. That's where you can correlate the neuron right from the optic nerve head to the macular ganglion cell. An auto rescan placement, DMO centration, and image averaging are ideal, and this give you a superb data which you can correlate and you can use in the management of the glaucoma patients. Now, when to use the OCT? This was another fundamental question. There was a lot of debate and a lot of discussion, but now things in the 2020 appear pretty much very clear with the higher resolution and the faster scan speed. When we see the imaging field continuum, the current status, you see that the visual fields take over somewhere here in between the mild and the moderate glaucoma, and they go all the way till the advanced glaucoma where you have the stimulus size 5. The imaging takes over the left part of this particular spectrum, where the visual field basically is yet to come into play. Again, if you see the prototype RNFL changes here, the RNFL floors somewhere in between moderate to severe glaucoma. So it becomes redundant as it approaches severe glaucoma, where the field completely takes over. Having said that, moderate glaucoma is the time where you have statistical measurements in both the imaging as well as the visual field testing, where you have statistical packages which can analyze. On either side, on the right side of it, that is where the size 5 fields and the 10-2 program take over, you do not have the statistical analysis of progression, but then you have to depend on the values of the mean deviation and maybe a hand-drawn linear regression analysis. Also, in some odd cases, you do have some ganglion cell element that is being left behind towards the end of the glaucoma, although that is not uniform across the board. But that can be definitely used in cases where the RNFL floors faster than the ganglion cell layer. But that is you have to choose wisely on a case-to-case basis. My personal preference would be more of field test as the glaucoma advances more. Now, because of the large range of normal values that we see for the normal distribution of the nerve fiber layer thickness, there can be a significant damage before there is a statistical abnormality that is presented to you by the machine in terms of a color change. Also, there are many cases in which you can have a nerve fiber layer atrophy, but definitely no change in the visual field. That is called as a preperimetric glaucoma. So you can have so many things that are possible even before the initial field defect starts. That definitely tells you that there is definitely a large playing space for usage of OCT if used in the right manner. Now, unmonitored progression on the continuum will cover this much of layer. That is, if you see in the glaucoma continuum by Weinreib et al., almost 2/3 of the continuum is unaddressed by the usage of visual fields. That is where our correct imaging methodology helps us a lot in making the right decisions for the patient, which we'll see in the subsequent examples. So current gold standard approach excludes half of the glaucoma continuum, considering that visual fields or visual field defects are considered as a mandatory gold standard for the detection of glaucoma. Now, how do you use these? These technologies have to be used very judiciously and carefully. You have printouts like this that come at the end of the examination, which is done by the OCT. This is a prototype Cirrus 5000 printout. Here, the important thing is in this image, though you do not have the macular ganglion cell map, we do take it differently or use a setting called as a PanoMap, where we can use all these 3 images together and then definitely correlate to come to a better conclusion. Now, important part about this is there are many sequences that have been described in literature, how to go about reading these maps. But only one different thing I would highlight is you have to give all these analysis backseat. Before that, you have to definitely examine the scan quality, what the machine tells you, and the segmentation. So these 2 are the most important of all the data that is available on this map, even before you start looking at all the other maps. So if this map and this scan quality score is off, then you would not be pretty much using the other data, because it would be giving you actually wrong information. Apart from that, a systematic approach, which is given in many other presentations and many other videos, is usually useful, and then you can come to the right conclusion. Having said that, I would always say that do refer to the ganglion cell and the macula map before you come to a decision. Similarly, this is the Heidelberg. This is the second reliable machine that I have been using for the past more than a decade. And here also we have those similar things. Here the images are pretty much better segmented, and you do have these segmentation lines appearing much more clearly. In case segmentation lines don't appear more clear like in these images, or if you have a doubt, you have to go back to the console and then verify on the screen, and then take it from there whether the imaging modality is accurate or not, and whether you should use the data for analysis. Okay, so all this is the most important image, including the quality scores and the averaging parameters. And with once all these are verified, then you can put this TISNet data into perspective and then use it for your management of glaucoma patients. Now, as far as progression is concerned, as I told you, it is a cornerstone of therapy. It is very, very important, and progression analysis is available in the Cirrus machine, which is very much like the event and the trend analysis in the visual fields, where you have the average RNFL, the superior, the inferior, and the average cup to disc ratio. Always remember, with progression, you will have a downslope in all the others, whereas the CD ratio will always go up because of the progression of the cup and disc size relative to each other. Again, having said that, the imaging protocols here are very important. That the R2 should be the preferred protocol, where you have all the horizontal and translational alignment which is taking place, which will make the imaging more reproducible and strict across the board. Apart from that, the quality score should be absolutely impeccable as per the user's recommendations, more than 7, or preferably, according to me, as high as they can get. As far as the same thing in the spectralysis is concerned, we have similar parameters that can be plotted. Each part of the RNFL can be plotted over time, and then you can get a linear regression of all those values, and it can tell you the decibel, rather the micron change over time, and you can attach statistical significance to that depending upon your knowledge of the accuracy of your machine and the imaging logic that is used according to your ophthalmic society or the glaucoma society guidelines. Similar progression analysis is available with the ganglion cell layer. This is the GC-IPL from the Cirrus, and here also you get 2 baseline scans similar to that you get in the visual fields, and then you get follow-up scans. Again, I told you the imaging criteria, the imaging modality, and the scan scores are very, very important. And then once you make sure all these are in place, then this becomes a simple what we call as simple interpretation of the slope of the graph and the reading of the statistics of the calculator. So detecting change and measurement of the rate of change are very, very important, and this helps us demonstrate change to ourselves as well as the patient and demonstrate the efficacy of the treatment. Rate of thinning in longitudinal studies till date had been 0.15 to 0.6 microns per year, which is the physiological one, faster in older age, but more than 5 micron loss per year. And usually in most of the standard machines can be considered significant. Imaging criteria remaining uniform across the board. Remember that statistically normal range is 32 microns, that is from 75 to 107. So anything that is started, the patient has started losing from the baseline in excess of 5 microns would be something which you would be seriously considering as progression, irrespective of what the visual field is showing you, considering that you have followed all the criteria of imaging rigidly. Now, let us take 4 prototype case scenarios, how you can use them, and where you could use the OCT alone for decision making. These case scenarios are very, very common, that occur in common clinical practice, because many patients, around 10 to 30% of the patients, cannot perform good visual fields or reproducible visual fields all the time. So this case scenario 1, the patient is not regular with follow-up. He may have an irregular dosing schedule. If you see the disc photo here in 2015, discs look approximately the same, but if you see the average NFL thickness, it has reduced from 94 to 79. Considering excellent segmentation, good imaging scores, you would give a lot of importance to this kind of imaging change. And you have the fields which are absolutely normal from 13 to 15. Now this is a change where you have almost a lot of progression in the green, followed by just something which is stepping into the pre-perimetric glaucoma range. but here you can see the fields are completely normal. This kind of patient, you would definitely change your method of treatment irrespective of what anybody might say, because it is definitely much more above the usual expected standard deviation of imaging in such instruments. So would you modify OCT treatment based on OCT in this case? Definitely the answer is a resounding yes. Now scenario 2, a patient is very bad with fields, and here you have it's because it's a subjective test, difficulty in fields is very common. Now if you can see here, there's a lot of fluctuation. Patient is not able to do the test properly. Here it being an objective test, imaging scores being very high, you can get a very reproducible change over time, and you can see that one part, that is the superior temporal part, has started thinning, and this patient was a case of angle closure glaucoma who was sensitive to all medications, so she couldn't be put on any medications, and because of the angle closure, SLT could not be done. The patient's pressures were not very high, baseline pressures were around 18, 19, but once we did the cataract surgery, the angle opened up and the progression literally stopped. You can see absolutely reproducible figures from September 17 to August 2018, there is absolutely no change. But before that, there had been a change of around 5 microns from the baseline to the place where the progression took place locally. Now, here again, you have a patient with severe fluctuation in visual fields. Now, you can see this is not a very uncommon picture in the GPA. Now, what do you make of it? Whether you should give it importance or not? And you are really perplexed, and you can't tell the patient any one direction in which we should proceed. So in these cases, if you have got an excellent imaging tool, you can see from imaging from 17 through 19, there is absolutely steady RNFL profile. There is absolutely no change or hardly any change to make a statistical difference. And such cases can definitely tell you that with confidence that all this can be ignored, and basically you can continue the patient with the same treatment and follow him more purposefully by using the OCT also. This is a scenario 3 where you have severe tilted discs. Now, myopic discs do give you their own problems in imaging, but where the imaging can be done with a circle of measurement outside the area of peripapillary atrophy or the staphyloma, you can get reasonably good measurements which are reproducible over time. Here you can see the posterior vitreous phase. So anything like a PVD changing the profile also you can easily make out in good imaging techniques. Even in these cases with tilted discs and staphylomas, you do get scotomas which are related to the disc tilt. There is no such question here. Whatever the profile will be the profile available to you, and over a period of time you can see that these are reproducible from 2011 through 2016. So such patients who have been initially treated as glaucoma because of some visual field defect, you need not bother, because all these will definitely give you the confidence to say that the patient is stable and the changing field defects might be just a fluctuation. You can definitely treat them on the basis of OCT when you take it in conjunction with risk factors and clinical examination. So now the last scenario here is you have ocular hypertension under treatment with well-controlled IOP and normal and reliable fields. Average RNFL shows decline. Now, a very important thing is the quality scores are uniform and the RNFL decline is less than 5 microns. Now, having said that, if the imaging, the standard deviation of the imaging is around 5 microns, anything that is playing less than 5 microns, unless I have a significant risk factor that is associated, or if the patient is one-eyed or something like that, with some things that we need to consider in addition purely to the imaging or the fields, then I would think about tampering with treatment. But most of the time, with such narrow differences, you wouldn't tinker with the treatment only on the basis of imaging. So judicious use involves decision making by using the right technology in the right way. So in such cases where you do not have a gross change or just a borderline change in the retinal nerve fiber layer, unless there are another associated factors or other structural abnormalities in the disc margin or in the macula which is starkly telling you a unidirectional change, you wouldn't change treatment just on the basis of a few micron changes in the imaging technique. Having said that, always make sure that the imaging quality scores are uniform, the images are reproducibly taken, and the segmentation is very good before making a decision in such cases. So take home message is keep it strict. You have to know where to use, which machine to use, and how to use it. Keep it simple with the imaging frequency and reproducible technique of measurement. Remember that a classical change is expected across the diverse glaucoma spectrum. Looking at the whole neuron helps differentiate classical glaucoma from non-glaucomatous optic neuropathy, and used judiciously with clinical correlation, keeping in mind the normal variation and the media changes that can affect imaging. Thank you for your patient hearing. I'm open to questions at the end of the session. Now we welcome Professor Edward. He's a noted international faculty, and we are just waiting to hear from him. So I shift the mic to you.
I guess I need to share my screen, right? You need to let me
Yeah. So
make me co-host or.
yeah, just let me give you a brief introduction of the professor. Thank you, Dr. Sachin, for the wonderful presentation. That was you had given very good practical tips about the OCT. So let me introduce our special guest today, Professor Deepak Edward. It's my pleasure and privilege to introduce you, sir. Just a short introduction about him, because he has so many things to tell about him, but I would just tell a few of them. He is the vice chair of education and professor of ophthalmology and pathology at the University of Illinois. He is an adjunct professor at Wilmer Eye Institute and also Johns Hopkins University School of Medicine, Baltimore, USA. He has been listed in the best doctors in America list for many years. He has over 200 publications and authored chapters in several well-known books. He has been awarded several awards and orations during his career, including ARVO Fellowship, Senior Achievement Award of AAO, and Lifetime Teaching Award at the University of Illinois. So it's a pride and privilege for us to have you here, sir. So today he'll be talking about 20/20 and 10 degrees of visual field. So he'll be giving us all those practical tips for managing our glaucoma patients, with severe defects. So over to you, sir.
Thank you. Okay, let me get my presentation up. So are you able to see my screen or?
Yes.
Okay, let me just, I think.
It's not.
Yeah, is that better now?
Yeah, we can see it.
Okay, wonderful. Well, thank you all for inviting me to give this talk early in the morning here in Chicago. And I enjoyed the previous two talks by both Dr. Deshpande and Dr. Tarwatkar. Very nice talks on OCT and management of glaucoma. So I'm going to address another different aspect of glaucoma, which not many people like to take care of these patients. People with severe glaucoma, severe visual field loss, speak to you a little bit about how I approach these patients. So this is a beautiful time of the year here in the Midwest in Chicago. The fall leaves changing color. Yesterday was Halloween. This is the picture to the right is specifically for Dr. Natarajan and for others, created by a very talented ophthalmology resident, carving out a pumpkin, showing the back of the eye. So enjoy that photograph. So let's move on to the talk itself. So here's a typical patient with this kind of a scenario, a 54-year-old female, difficulty in seeing at night, glare, complaints of glare, things getting worse. Vision is 20/30 and 20/40, intraocular pressures 17 millimeters and 3 medications. And then you can see on a Goldmann visual field, a large temporal island in one eye and a central island with split fixation. And on a 10-2 visual field, a central island. So what do you do with a patient like this when you see them the first time? So we'll touch on various nuances in this scenario throughout this talk. So this type of glaucoma, or severe glaucoma, is somewhat of an enigma to many physicians and those who take care. It's difficult to define, it's difficult to monitor, and of course, the stakes are high in this type of glaucoma. So we're going to talk about what is severe glaucoma, the challenges surrounding severe glaucoma, how do you take history, how do you take vision, how do you take intraocular pressure and other things. So these all seem like mundane things, but on the other hand, they're important, and you have to sort of change your approach a little bit when you deal with patients with such severe disease. So what is severe glaucoma? Some people say, well, I know it when I see it, like the picture you saw with a patient with a very severe visual field loss. The Advanced Glaucoma Intervention Treatment Study defined glaucoma, severe glaucoma, is that one that cannot be controlled by medical therapy alone, and in which there has been some visual field loss with a mean deviation of at least minus 10 decibels. So we don't really use this definition more often, but more commonly use the definition created by Hodap and Anderson Parrish, where the visual field, global loss of visual field is greater than minus 12 decibels, or a field that involves 5 degrees of the central visual field in 4 para-central locations in the 24-2 grid. And I'll show you some examples of that. So here's another field, doesn't look too bad, but you can see these points that involve the central grid. And according to the Hodap Anderson criteria, this would be a severe visual field loss. So here you see, again, a large degree of hemifield loss, but you also start to see early loss in the second or the inferior visual field. This becomes much easier. Central points start to be involved, and also the inferior field is involved here. I'm sure all of you have seen these sort of visual fields where you have this severe visual field depression, and which does not show up on the pattern standard deviation plot. And I'll talk more about this kind of visual field a little bit later. So why do we worry about these patients? So at the time of diagnosis, many patients may not be functionally impaired in at least one eye, but having more severe visual field loss at baseline is associated with greater visual field loss, a risk of future visual field progression. So this is, I think, something that worries everybody, that you see if someone with a central island and you're worried that visual field progression will get worse and these patients will go blind. So having more severe glaucoma at baseline also increases the likelihood of more rapid progression, not just progression, but rapid progression. So the odds of visual field deterioration are accelerated by approximately 11% for every 1 decibel worsening of visual field at baseline. So 1 in 10 patients, or 1 in 10 likelihood of the visual field getting worse. It's not too bad, but the risk is greater than somebody with mild to moderate glaucoma. There's approximately a 23% increase in faster component of visual field progression for each log 0.1 unit of increase in baseline cup to disc ratio. So to practically point this out, someone with a 0.8 cup or a 0.9 cup versus a 0.5 cup or a 0.84 cup versus 8.5 cup would be at a greater risk of developing greater visual field progression. So the take-home points really about with this ominous message is that patients with severe glaucoma are more likely to transition to functional visual field defects, more progression of visual field loss, and more rapid progression. So the stakes are high. Most patients that go blind, again, from glaucoma had severe visual field loss at the time of the diagnosis. So if you look at this paper, again, this came out of the Mayo Clinic several years ago, in a very nice practice, a very well-known practice. In 34 years, under very good doctors' clocks, 56 out of 290 eyes of patients progressed to blindness. So now, is the reverse true? And this is what I want to emphasize, that even the question we are asking is, do most patients with severe visual field loss go blind? And the good news is the answer is no. So most patients with severe or end-stage disease, and this is a very nice paper, I think would encourage you to read this, patients with follow-up to up to 8 years, only 10% of patients progress to visual acuities of 2200 or worse, or lost 3 decibels in the mean deviation. And so this, in a practice where you're taking good care of patients with severe glaucoma, this is probably a more realistic figure despite all the warnings. So the previous slides basically showed you that the stakes are high, that there is a risk. But I think if you take good care of these patients, most of them will do fine over a lifetime of the disease. So what are the functional type impairments that you will see from asymptomatic disease to one causing increased functional defects? So the functional impairments include a risk for falls, accidents, motor vehicle accidents. In the US especially, there's a stigma and challenges regarding driving restrictions. Patients don't like it when you fill out those driving forms. There are socioeconomic challenges, as unemployment, health case challenges, loss of independence, and of course, a wide variety of mental health issues, including fear, vision loss, anxiety, depression, and patients often get dependent on different types of chemicals, alcohol, to ease their fears and anxiety. So how do you evaluate, how do you monitor, and how do you manage these patients? So on an initial visit, I think you evaluate the patient and with the asking histories for usual glaucoma risk factors. I think you need to become a real doctor here also and look for other risk factors, especially in patients who have maybe normal pressure glaucoma. I also ask these questions in patients who have severe glaucoma. They come to me usually on multiple medications. You want to get a history of hypotension, which increases the risk of visual field loss, Raynaud's phenomena, which is more associated with low tension glaucoma, sleep apnea, blood pressure meds, especially those that are being taken at night. Patients might state that their blood pressure is excellent, but you need to ask the actual figures. Blood pressure measurements at night often compromise circulation to the optic nerve at night, as was previously pointed out. And also other types of activities such as yoga, standing on the head, increases intraocular pressure. Wind blowing instruments, I think, are something that you want to know if the patient is playing those, because that can cause extreme elevations of IOP by increasing jugular vein pressures and chest compression. The type of diet, patients use all kinds of interesting diets when they have severe glaucoma. Family history, if you look at the studies itself, the association, other than in siblings, of glaucoma progression is low, but very often in patients with severe glaucoma, you will get anecdotal history of somebody in the family going blind, and I think you need to take that seriously. On follow-up visits, again, visual history is important. You address complaints. I think you have to listen to these patients with severe glaucoma a little more carefully, because as you will see, that the testing that we do has its limitations, and history becomes very important, as we'll see. You want to also reconcile other history that you take at the initial visit at least once a year, and if not, at every visit. Visual acuity measurement becomes important in these patients. And of course, if you're taking Snellen acuity, you want to record vision in numerical manners, even if the vision is worse than 2400 in some of these severe patients. I know we are talking about a scenario of 20/20, but you will have patients who have 660 or worse vision. And I think having the patient come closer to the chart, having the patient having single opter types, which are large, which measure visual acuities worse than 2400, are nice to have in the clinic for two reasons. You have a numerical way of measuring it, not just counting fingers at 2 feet or 3 feet. And the second, the patient feels a little better that they're able to see, quote unquote, the chart. It's a little bit more psychologically encouraging. You want to use the same lighting conditions at every time, because changes in lighting in the room, different charts can make a big difference in these patients with markedly constricted visual fields or very severe glaucoma. Now, it's very important to watch the head position in these patients while taking visual acuity. So some of your patients will have large temporal islands through which they can see 2400 or 2200. So they will tilt their head so as to expose their temporal visual field to the chart. So, for example, a patient has a right eye severe glaucoma. The patient will turn their head to the left and take and see the chart. So if your technician or someone who's helping you ask the patients to look straight, they will not be able to see those big letters. And this becomes an issue and causes some degree of panic to a doctor. Patient was 2400 at last visit, today it's hand motion. What happened? So sometimes you have to, and I do very frequently, just recheck the vision myself. And more importantly, just ask the patient, have things gotten worse or are they the same? And I would say 9 times out of 10, patient will say everything is the same. The technician did not take the vision the right way. Another pearl I'd like to share with you is that very small media opacities make a huge difference in the quality of vision in these patients. Patients who have 20/20 vision or 20 or whatever level of vision, you might have a small corneal scar that's recent, or more commonly, mild posterior capsular opacification, or some other stuff going on in the media that makes a difference. And the patients will complain bitterly of changes. A little bit change in refraction, a little bit nuclear sclerosis makes a huge change in the vision. So I learned this from the retina folks, especially from patients who have severe retinitis pigmentosa. You have someone with a mild capsular opacification, they're complaining of decrease in vision. Their vision on the chart is still the same. You do the YAG capsulotomy, and all of a sudden, the patient tells you that their vision is back to where it was before. So keep this in mind while assessing your patient. The actual numbers on the chart may not change, but the quality of vision will change. So coming to the actual assessment of glaucoma, so the first is the disc. I think we very nicely heard a comprehensive view of how the OCT is used in glaucoma. But in severe glaucoma, disc photographs, OCTs are not very helpful, because when you have cups that are 0.9 or 0.85 or 0.8, the change is very hard to determine whether this includes the cupping as well as the rim change. So I really don't do photographs, order disc photographs in patients who have very severe glaucoma. How about the RNF analyzers or disc analyzers? So as we very elegantly heard, that these instruments are highly sensitive in detecting disease, but they are probably more useful in early disease to determine progression, or from progression to normal to glaucoma. In severe glaucoma, the use of these machines is somewhat limited, as very, again, nicely pointed out. There is a flooring effect where there is only that much of the thickness of the retinal nerve fiber layer, which is also consists of astrocytes and extracellular matrix. The nerve fiber layer will thin out, as you see in this particular patient with severe visual field loss till 20/20, but you can see the marked loss, and you can't really tell the difference between this and further nerve fiber layer loss in a retinal nerve fiber layer, circular retinal nerve fiber layer scan. So it basically hits the floor. So which eye here is NLP? Can you hard to guess from this picture? So you can see the right eye here was NLP and the left eye is 2200. Again, the OCT doesn't give you much information. Now, there may be some benefit of the macular scan, as was pointed out before. Remember, the macula contains about 50 to 60% of the ganglion cells in the retina. It is about 4 to 5 layers in thickness. So looking at these scans on a qualitative basis, and I say qualitative is that you eyeball it, because the progressor analysis for macular scans in severe glaucoma are not very well validated. So you sort of have to look at it to see if there are changes that occur in the visual, in the OCT thickness in the macula. It's somewhat helpful. There are papers out there. I do use it in patients. It helps me add more information to the visual field testing that is done in the patient. And as pointed out before, there are some patients who can't do visual fields very well. This provides an additional complement to visual field testing. So in summary, OCT photographs are not very helpful in managing end-stage glaucoma. Keep the macula OCT, the RGC layer scans, hold some promises, still needs to be validated, but you can use it to complement your visual field testing. So perimetry, again, to emphasize, is really the mainstay for following patients with severe glaucoma. But there are unique problems in patients with severe glaucoma and visual fields, and point some of those out to you. So the 24-2 size 3 object is not very helpful in severe disease because very often there's increased number of false negative errors. There's a great degree of variability. There's limited patient cooperation, increased fixation losses. The indices might be misleading. And the resolution of the central field is very not good, and there are very few points to follow. Having said that, if someone has good vision and a large central island, this is something that you may want to do if you have good baseline from several years ago. So I've had patients who have had a large central island, very reliable fields. I followed them for 15 or 20 years. Most of their fields are 24- size 3. Occasionally, I will test the central field. There's a newer visual field test available. I think it's called the 24-2C3, where it has visual field testing in the 24-2 area, but there are additional points available in the central visual field where it can monitor the central field. So I think upgrades of your Humphrey machines have this parameter available for visual field testing. Came out about a year and a half ago, I think, in the US. We've had it. I've not used it that often, and I'll tell you why in just a minute. So here, this kind of field, doing a 24-2, here's a patient who's 20/20. I saw recently, and this is not very helpful. Again, the central field is markedly depressed, the peripheral field is markedly depressed, and you really don't see the pattern deviation. And doing fields over a period of time in a patient like this is not very useful. You'll see the mean deviation. You might see some fluctuation in the mean deviation and the pattern standard deviation. The visual field indices might change or may not change, but overall, it's not that useful, or not. You can't follow the patients very carefully using this strategy of field testing. So other options available to you are 24-2 using the size 5 object, or 10-2, the size 3 and size 5 objects, the macular threshold, and of course the Goldmann visual field, which is not very readily available, and you don't have good technicians. So a 24-2 size 5 object is useful in patients where there's very severe visual field loss and poor vision. So for example, someone is 2200 or 2100, you can test the visual field. It gives you an idea of what the visual field is doing. It's a longer test and may be subject to increased errors, but there's less variability than the size 3 target. And if you have a patient with a central island and a large temporal island, this might be a more visual, more useful in these patients if you don't have a Goldmann visual field available to do that. Let's see, let me go back. So many of these patients with small central islands, the 10 degree field or the 10-2 visual field is probably a better field to follow these patients. It increases the number of locations that can be monitored in the central visual field. It has a 2-degree resolution. And the downside to it, is the test is fairly long. It does not have the CETA algorithm built into this testing strategy. So here's a 10-2 size 3 visual field. you can see that the time duration is about 9 minutes. So it's a long test. You have many more test points. It does have visual field indices available. And once the patient gets used to doing this kind of visual field, it becomes a pretty good test to monitor these patients. Here's a patient again who's had severe visual field loss. That's his 24-2 size 3. Here's the 10-2 size 3 visual field in the same patient, showing you how you can monitor the central points of visual field loss and change here, because that's what we really want to monitor in these patients. So this is the time of switch. Some doctors or some glaucoma specialists will order both these visual fields in a staggering fashion. I do this in some patients, but often it becomes an issue of insurance. In the US, unless you really justify it, insurance will not pay for more than one visual field a year. For severe fields, you have to provide specific justification why patients need more than one visual field a year. This is the criteria much easier in Europe, where the payer system is a national healthcare insurance system. Now, what about the size 5 visual target? The size 5 target is an excellent test for patients with central islands, even those with severe visual field loss or fixation loss. There's less variability in severe glaucoma. And the size 3 target to the size 5 increases the target size area by about 16 times. There's an increased dynamic range, meaning there's more steps in the testing, so it's much longer test, and the variability is decreased. Now, this visual field testing does not have indices or statistical indices. You need to look at what are known as the quad totals to determine change. So here's an example of a field like this. So here's a patient on your left has had a stimulus 3 10-2 size 3 field, and you can see that the field is getting really bad. And here is a 10-2 size 5 visual field test. Notice that the test duration time is about 13 minutes, and gives you what are called the quad totals. It basically sums up the number of the decibel quantification in each quadrant, and if there is change in any quadrant, you'll see decrease in this number in each quadrant. So you kind of have to manually look at this. Newer electronic medical health record systems such as the EPIC, you can enter these numbers in them. It becomes easier for you to follow this field over time, but it is an additional task to do. There are no indices to follow these patients. So here's a patient, again, just showing you how one is following a patient with 10-2 size 3 visual fields over time. Again, very stable patient, but you can see that this is how you want to follow these patients. The other thing that I want to point out is that in these patients who have very severe visual field loss, there can be quite a bit of variability. So you can see how the field gets a little darker, more lighter, again becomes lighter. So there is variability, and especially if you see worsening of the visual field, you really want to repeat it, especially if you're going to intervene or make some sort of surgical intervention or other kinds of intervention to further lower the intraocular pressure. So like I said before, indices are not available. It's sort of a manual judge in these size 5 stimuli. Now, you can also there's another field test you can do, which is not usually used, and I've used it on a few occasions, where you do the macular threshold test. This is for about 5 degrees of visual field remaining, and it gives you a gross estimation of the visual field loss. Most of your machines have it, but you don't really look at it. And here's a patient we've looked at over years. Here are the Humphrey visual fields, the 24-2. The 10-2, and there's absolutely no information. The 10-2, this 5-degree macular threshold test gives you some information of what's happening to this particular patient. Goldmann fields are nice, but of course, it's dependent on whether you have it in your office. Some of the newer machines have this, the ones by Hogstrite have this incorporated as part of the testing strategy. There, of course, is a qualitative degree to this, but the most importantly, you really need to have a good perimetrist who understands the test. Otherwise, it's a useless test. So here you see a patient with a central island and a large temporal island in the periphery. And in your in your Humphrey visual fields, you're really measuring only this. You're missing out on this visual field. Is that important? Maybe yes, maybe no. But this is what's responsible for acuity. And I think that's what you really want to measure. So how often should you perform visual fields? So as I was pointed out before, you need several fields to measure, to determine baseline. Sometimes we have the luxury of doing that, and sometimes we don't. In a referral practice like mine, we often see patients who had all of that done elsewhere. Sometimes we have, and sometimes we don't have the medical records. But I think with severe glaucoma, the kinds of patients I show you, I think you want to monitor them at least twice a year. Things change, and especially when the visual field is involved in the central location, stakes are high, and you want to be monitoring them soon. Patients who are unstable, I think probably need to be monitored at least twice a year. So how do you judge progression in these patients? So in patients who have OCT as well as Humphreys and mild to moderate glaucoma, they're very nicely set criteria. You have very good progressor type analysis tools which will judge event change or will judge trend change. The rates in severe glaucoma, these progressor analysis tools don't work very well. So we hope that in the age of AI, and there are a number of people working on this, that tools that are newly developed to help this very vulnerable group of patients will help us better in understanding how to determine the rate of progression. But having said that, we can't wait. We have all these patients in our offices with these bad fields. So you have so-called fast progressors and slow progressors. So patients who progress fast account for about 3 to 19% of your patients with severe glaucoma. And what do I mean by fast progressors? Someone who progresses, again, the definition is vague, but for me, someone who progresses more than 2 decibels in 1 year is a fast progressor. So those are the patients you need to watch very carefully. But the question is, even before you reach to that stage, how can you determine or understand who are the eyes or which are the eyes of patients who are at a greater risk of high progressions? So certain categories of patients, for example, of course, patients with pseudoexfoliation are at a higher risk of faster progression. Patients who are high myopes are at a higher rate of progression, a rate of risk of faster progression. Those who had higher baseline IOPs, who have greater fluctuation of IOPs, and of course, those who are poorly compliant or who don't understand the seriousness of the disease, these are all eyes that are greater risk of greater progression. So what do you do for these patients? Of course, you monitor them more carefully, the more aggressive, and most often you end up doing surgery in these patients in order to lower the intraocular pressure goal or to achieve the goal what you want. Now, also, I want you to understand with these severe patients with severe glaucoma, there's considerable amount of noise and fluctuation in visual field testing. So often you have to repeat tests to make sure that the test, what you're seeing, is a true change before you completely change your drug regimen or you do surgeries trying to achieve intraocular pressures in the low teens or even in the single digits. So you need to be careful and not hesitate to repeat visual fields to make sure that there is actually progression in your fields. So remember, most patients will progress at a very slow rate, maybe less than 0.5 decibels a year. Another pearl I'd like you to share with you is that in your office, you get lost in the forest if you don't look at the trees. And what do I mean by that? You're looking at visual fields, it's a busy office, and you look at only the last 2 fields. I think at least once a year, if not every once in 2 years, I think it's nice for you to look at the first visual field you got done for these patients and see how things have gone. And sometimes I'm surprised as well that how badly the patient has done under my clock, that things have changed. I have not realized it because I've just looked at the previous visual field of 2 fields before and not paid attention to what has happened over time. So here's a patient. Again, visual acuity in these patients become an important way to look at the visual field deterioration. Here you see a patient in 2001 with 20/40 vision. Vision is getting worse. The field has changed, it's fluctuating, but things have gotten worse. So if you look carefully at visual acuity charts and how visual acuity it is, talk to the patient, you will see how things may or may not get worse under your clock. So pay attention to visual acuity, even small changes in your office. So I like to call it the how are you doing test. So ask the patient how they're doing. Is their vision getting worse? What's happening with the quality of their vision? And often that'll give you a clue as to what's happening. So in summary, perimetry remains the mainstay for monitoring this disease. Imaging hits the floor. You can monitor central visual field by 10 degree or 5 degree with large targets. And don't forget to ask the patient how you're doing. So what's the IOP range or goal? So of course, in these patients, as previously pointed out, you want a IOP goal in the low teens. Many studies have shown that if you can maintain the intraocular pressure in the low to mid-teens in these patients with severe visual field loss, that you can halt or you can the progression of visual field loss over many years. But having said that, don't chase after numbers. So if the pressure is 15 today and 14 today and 16 on one visit, don't panic. Don't make the patient panic. Bring the patient back for a visual field IOP test. Remember, these patients have very limited visual fields. They have a hard time putting drops in. They might have missed something. There are all sorts of statistical issues that cause the variation in the IOP measurements we don't have time to talk about. Also, remember, there's an error in your machine of +-2. Also, again, medication compliance is something that you really want to explore. Ask open-ended questions. And then if you want to achieve your intraocular pressure goal, you have lots of tools available, such as lasers, which are not very helpful, but surgery often is the way you want to go. So this is a kind of a busy chart. I can share this with you later. This is how I think when you have a patient who comes in with severe glaucoma, with low intraocular pressures in the office, but with severe visual field progression. So you look at visual fields, you look at IOP criteria, and look for external criteria that might have changed the visual field, such as retinal problems and CNS problems. But I'm going to leave this here because I think otherwise we probably don't have the time to go over that. So in terms of trying to lower the intraocular pressure in a meaningful way, to the low digits, if medications can't do that and the visual fields are progressing, I think trabeculectomy is probably the surgical procedure of choice. Shunts, again, with medications probably can get you down there. I think you probably have to be somewhat daring in these patients where if you have sutures, you probably want to laser suturelize them, or suture, if you have releasable sutures in the trabeculective flap, you want to pull them down early. Sometimes you have to deal with a shallow chamber. Paul Lichter, who's a very famous retired glaucoma specialist, he said, Deepak, you really need to see a shallow chamber and a pressure of 4 with choroidals in the early course of glaucoma, a patient with severe glaucoma, if you want to achieve single-digit IOPs, and I think is true. Also, in these patients, make sure you, again, monitor their blood pressure history, systemic medication history. And then we come to the subject of neuroprotection. Is there something called neuroprotection or not? And this is an area which has been explored, but there is no definite answer. A lot of your patients will ask you about alternate therapies, So long story short, there really is no clear evidence-based literature to suggest that any of these medications really do help. There are small studies suggesting that medications such as ginkgo, vitamin B3, and a medication known as citicoline, which is again reduces stress response, can protect the ganglion cells. So do I prescribe these medications to the patients? Someone with severe visual field loss was very anxious. We know that many of these have no harm, but if you're going to advise the patients, you really need to understand the dosage, make sure that you give them the right dose. Bob Rich, who is a glaucoma specialist in New York City, is a big proponent of this. He actually has formed a company which provides a drug called glaucocetium, which has a smorgasbord of medications available in that. And patients here are clinging for hope. So as long as I think you do no harm, you have something to give to the patient. I don't know if it's a placebo effect or a real effect. It's something to offer them for them as a hope. So, but if you're going to prescribe, understand your medications, understand what they do, understand drug interactions before you embark on providing alternate therapies to your patients. So what about the wipeout phenomenon in these patients? So I'll make the long story short again, that this is an extremely rare phenomena. It happens. So don't be scared to operate on a patient with severe glaucoma. Their vision will go down in the immediate post-op period. And I would say 98, 99% of their vision will come back after maybe a month, maybe 6 weeks. There are several precautions you want to take. I don't think we have the time to talk about that when you operate on these patients. The main thing is you want to make sure in the perioperative period, you don't give that eye a chance to have high intraocular pressure. So be very judicious with the retrobulbar block, or even give general anesthesia, more peribulbar block, or infiltration anesthesia. That's what I do in most of these patients. I don't give them a block. Monitor their pressure in the immediate post-op period to make sure that they don't have a pressure spike, and watch them very, very carefully in the post-op period. Most of the visual acuity loss is due to your tight sutures for the closure of the conjunctiva. Remember, I said a small change in anything in the media, a small astigmatism created in these patients will drop their vision from 20/20 to 24 or 100 or counting fingers, and we panic. Most of these patients, the vision comes back. So I'll leave that message with you on that. So there are a number of patient concerns. You know, they're 20/20, they complain they can't see, they have glare. And the phenomena of glare that they describe to you is really a loss in contrast sensitivity. Everything is washed out. Patients, especially who go to the grocery store where there are bright fluorescent lights, they can't see anything. They can't see the labels in the store on the things that they're trying to buy. So simple measures such as a brimmed hat, the hat with a visor, will cut out some of this light and glare and improve their vision quality much better. Fishing glasses, something with an orange tinge which takes out the glare in the orange spectrum. Patients appreciate that. Again, not dark orange, but light orange is helpful. Don't be, ask the patient of what the visual needs are. Low vision aids can be helpful. Newer computers are very useful for these patients. Support groups, again, be an advocate for your patient. At the end of the day, the patient doesn't care much about his intraocular pressure or his visual field. He's concerned about what he or she is seeing, how he or she is living in their little microenvironment within their homes. So if you're able to address that, you'll have a very grateful patient. So in conclusion, most patients with severe glaucoma are going to do fine. That's the good message. But you really need to modify your approach on how you approach these patients. You need to be careful as you look at them, modify your approach. You need to be curious about what I mean by curious is you need to really mentally think on how to deal with these patients, how to deal with progression, to figure out if there's really progression. You need to be caring for these patients. Make sure you understand that you care, to show that you do care about them, and provide them not just care, but compassionate care. And you'll have patients who are grateful for what you're doing to them. Of course, the wow effect is not there like you see in a cataract surgery, where a patient who has a white cataract goes from hand motion to 20/20, and you see that sparkle in his eye. You don't see that in these patients, but you will have quite gratitude from these patients who have a very difficult disease. So thank you very much for your attention. I think I've gone a little bit over time. Sorry about that, but I hope this was a useful talk.
Thank you very much, sir. That was a wonderful talk. All the practical aspects, especially, you have covered. These patients are very difficult to treat and to tackle. Actually, it's very difficult for us to say. It's very easy for us to say, that nothing can be done about this because your vision is very, very low, and it takes a great effort, not just from the patient but also from the doctor to take notice of all the difficulties that this patient is having, and to help him practically to solve those difficulties, and to maintain, most importantly, maintain his vision, whatever it may be, to maintain it throughout. So at least he has some useful vision left. So thanks a lot, sir. Please send in your questions. We are ready for the questions. Please type it in, and we'll be very happy to answer it for you. Dr. Sachin, any points for discussion you want to have?
Yeah, Professor, good evening. That was a very enlightening talk from you. So I would like to ask you a couple of questions regarding this. As you rightly said, in these cases, even a small amount of media opacity makes a lot of difference in their quality of life as well as their functionality. So when we are trying to do cataract surgery in such cases with advanced visual fields, are there any special precautions that you would like to tell us?
So you bring up a good point. So cataract surgery or even glaucoma surgery. So if you're just doing cataract surgery, I think one is, I think topical anesthesia is something you want to do and not give a block. If you give a block, and you probably don't want to do too much of massage on the eye. Sometimes if I have the luxury, and these are often older patients, if I can give general anesthesia, I'm not hesitant to do that if I need to do it, especially monocular patients. I will also make sure that after the cataract's done, try to keep the bottle height low as possible. The newer machines have, the ability to actually control the intraocular pressure during surgery. Also, very good cleaning of viscoelastic in the eye. If you're doing that, make sure you get the viscoelastic out so that you don't have a pressure spike. Now, most of these patients, when I operate, do just cataract surgery, I'll do them the first thing in the morning, have them sit around till the afternoon, and tell them that I'm going to be checking the intraocular pressure in the afternoon. And you'll be surprised how many people will have an intraocular pressure spike, even in the presence of a trabeculectomy of other procedures. The other additional thing I do, and there's a nice paper for you to read, and I can send you the reference there. I often give them Diamox, these patients, before surgery. So you want to give Diamox about an hour or two before surgery. The greatest effect is somewhere around. Now we have. Do you have long-acting Diamox available in India, the sequels, or no?
Yes.
Yeah, sequels. So I usually give them sequels, and so it lasts for a bit. And often I'll give them another Diamox sequel at night, even if the intraocular pressures are well controlled in the preoperative period. I do that. So those are some of the precautions I take. Intraoperatively, you want to make sure the pressure is not high. Postoperatively, check the pressure. Make sure you clean viscoelastic well, and those are the kind of precautions I take. And it's very similar in trabeculectomies in these patients. You want to make sure that they don't have a spike. One patient that I had lost fixation in several years ago, I recall, the patient had a pressure spike of 50. and basically went from 2030 to 2200. Most of the patients with the trabeculectomy and other techniques we have today, they don't lose fixation. The wipeout phenomena is very, very rare, but it is something of concern. I discuss it with the patients that it is a possibility even if the risk is low. So the stakes are high, but I think you have to deal with it when you have to deal with it.
So, sir, do you prefer to keep such patients on maximum medical therapy along with the oral Diamox for a long time?
It depends. It depends. So, for example, I mean, a good point. So, if the patient was previously on 2 drops, you've done a trab in the past or a tube. Tube has become a fashion in the United States. I'm one of those dinosaurs who still does trabs. These are patients not for mixed type procedures. So if they were on medications, the answer is yes. If I did topical cataract surgery, I'll have them start the medications on the same day, including the antibiotic and steroid, and put them back on their drops immediately. So the short answer is yes.
Okay. And
now, as we know that intraocular pressure does come down after cataract surgery, so I think that algorithm is more for patients with mild or moderate glaucoma. Remember, these patients, their meshwork is probably completely shot, and I don't think it makes much of a difference of cataract surgery lowering intraocular pressure in these patients with severe glaucoma. I don't think we should be thinking about that in these patients.
Okay, so classically, when will you, operate those patients, like doing a trab or maybe a retrab or putting a tube? So when do you basically feel that, the medication is not working and I should go and operate? So what should be that thing that we should keep in mind? When to operate such patients?
So these patients, again, if I have, we're talking about the severe glaucomas, correct?
Yes, yes.
Yeah, so if I see visual field change, which is confirmed, and I'm sure that there is a change, and I want a lower pressure in these patients, typically, if they've had a previous, let's say they had a previous trabeculectomy, okay? In these patients, today, I have the option of putting a Zen implant in there, which would be my procedure of choice in these patients. I give more mitomycin C than I would usually do if the trab had scarred down in another quadrant, and put the Zen in. The goal in the end becomes a procedure where you have pressure lowering with the new surgical procedure plus additional medications. So I tell the patient the surgery is not, you're not going to get rid of your medicines most likely. You're going to get lowering of your intraocular pressure. Think of this as a big drop, another medication which is more effective. So that's my approach. Trabeculectomy is doing a second trabeculectomy in an eye that has a trabeculectomy before. The success rate is not that great, and I'm sure you've had the same experience. Those are the patients I end up doing a Baraval type tube or tube, with a large surface area. That approach is also a little tricky, as you know, because you tie the tube off in these patients. These patients can have a pressure spike. Often what I do as a technique is I actually fenestrate the tube with another ninovical suture in the post-op period and put them back on maximal medical therapy till the tube opens up. How do I get pressures in the single digits? It's challenging, honestly. It's easier in a patient who hasn't had a trabeculectomy or a procedure before. I think you can become aggressive, like I said, do a trab and make it almost full thickness earlier on in the post-op period. Take the releasables out soon or suture lies very soon. AC gets a little shallow. You treat them aggressively. You're more likely to get lower IOPs in such a patient. But it's challenging to get a patient. There's no way of controlling on which patient is going to get single-digit pressures or not. Thankfully, again, realistically, there are very, very few patients in my practice over the last 25 years where I had to resort to such aggressive measures. It's rare that you have to do that.
Okay.
Yeah,
And
one more small question first on advanced glaucoma is that nowadays all these modern machines are actually equipped with size 5 stimulus as well as the kinetic perimetry. So when we have a 10-2 size 5 test to fall back on, what is the place for kinetic perimetry in such cases? Do you still end up doing it in some cases, or 10-2 size 5 will solve the problem in most of them?
So, we're blessed with some very good perimetrists. Even now, the automated perimetry, the machines that are available, which have automated kinetic perimetry, I don't find them very reliable. They have their own drawbacks. It's good to do a quick visual field. There's quite a bit of variability, despite what the companies say that it does. We have one machine. We've tried the kinetic in severe glaucoma. Remember, these patients don't have very good fixation. They move around. Unless you have someone monitoring their fixation while they're doing the fields and they know where the previous defects were, you need a good perimetrist. So we are doing fewer. The best perimetrist we have is about to retire. And I think and the ones that are younger don't want to learn how to do that. So we're more and more switching over to the 10- to Humphrey visual fields to follow these patients. So there is a role. I think the key factor is to have an excellent perimetrist who can monitor the automated field while you're doing that. So that's the way I look at it. I rarely use the automated feature.
Okay.
So I can tell you the only place where I really use it is, so in the US, if you have impaired vision, the patients come in and almost on a weekly basis, we have a patient for a renewal of driver's license. They're about 85 years old. They're still driving. They want this field test done. So we only have to test the 5-4E and the 3-4E target. So we put them on the automated machine. They're finished in about 4 to 5 minutes an eye. We're done. And we give them the report. But otherwise, for a high-risk glaucoma patient, we really don't use that.
One last question from my side. You did mention about other risk factors like hypotension and sleep apnea. So how common are these two factors in your practice? Because out of the recent literature, we have found alarming rise in the incidence of sleep apnea in the general population. So that encompasses those having glaucoma too. So how far has sleep apnea and hypotension been a part of the risk factors that you get to face in a day-to-day basis?
Excellent question. So sleep apnea is a big problem. It is a huge problem in our population. And you kind of pick this up and you start asking questions. You have a slightly obese patient, and sometimes you just pull their lids, they're kind of floppy in the clinic. So immediately that alerts you to ask that question. It is an issue. It's a modifiable risk factor, so I pay more close attention to it so that at least they can get their CPAPs and be able to do that. Having said that, I had this patient recently, a disaster, who has sleep apnea, severe glaucoma. I did a Barbell shunt on her. Her sleep apnea, the mask slipped over her eye in the post-op period, and basically the whole wound dehisced. Well, that's a side story. But I think that's a modifiable risk factor, and I think it's common. You have to ask the question. People won't volunteer. They might not know that they have sleep apnea. Often, if the spouse is in the room, you can sometimes get the answer, yes, my husband or my wife, they snore, and all of a sudden I feel that they stop breathing. So I think, or you can ask the patient about what their symptoms are, very tired in the morning when they get up. So I think that's something you need to ask. Hypotension, again, one has to understand what is hypotension. What kind of hypotension are we talking about? So we want to look at hypotension where the blood pressure is low enough that might cause hypoperfusion to the optic nerve, right? So it has to be below the mean arterial pressure. It needs to be lower than the intraocular pressure to do that. So you're talking about blood pressures in the diastolic of 50, 40, or 60, and a systolic of 70, 60. And those kind of pressure, blood pressures are worrisome. The 100 by 60, 100 by 80, I don't think those are patients who are really hypotensive. Giving hypertensive medications at night, or hypertensive medications, it can be an issue because we don't know what's happening at night. So I think most internists now are aware of that as well. So you don't want to give that at night. Now, is there a study showing that it makes a difference? The answer is no. But it makes practical sense. You can't do a study for everything, right? So we know it's a risk factor. So now, let's say normal tension glaucoma patient does have hypotension, right? Real hypertension. What do you do about it? That's also a very difficult question to answer. So I'll tell you what a lot of people do here. We'll ask them to drink some tomato juice at night, or eat a bag of salty chips. That's basically giving them more sodium at night, hoping they increase their blood pressure. Some physicians will refer them to an internist, and they'll get oral corticosteroids, especially the fluorinated ones. I don't do that myself. I don't feel I have expertise enough to do that. Have I done that in my career? Probably 2 patients, maybe. I've sent them. Did it make a difference? Again, it's anecdotal. These patients lived till their late 80s. They were still staying before they died. So I don't know if it had anything to do with giving them fluorinated corticosteroids, but these are options that are available and kind of makes common sense, but you have to be careful, right? There's a risk versus benefit ratio. And I'd rather have an internist or a cardiovascular doctor take care of it rather than me.
Thanks a lot, Professor.
Yeah, we have some questions here. We'll just take a couple of questions and then
Sure.
we'll stop. Yeah. So do you make any changes in your operative technique while doing TRAB in such patients, as far as the technique is concerned for the TRAB?
Okay.
Or it would be the same as you would be
more
doing?
the perioperative care that I talked about, giving them Diamox before. If I almost never give a retrobulbar block in these patients. I use a technique, a general anesthesia, if I have the luxury of being able to do that. Or if not, even not a peribulbar block, what I will do is I'll give them some either subtenons anesthesia or just infiltrate anesthesia in the superior subconjunctival quadrant. I sort of judge this preoperatively. The patient's going to be cooperative enough. When I do an iridectomy, I'll inject some 1% lidocaine in the anterior chamber. I'll give them pilocarpine before, because once you give the lidocaine, people start to dilate. It's hard to do the iridectomy. With a combination of so there are 2 times when the patient has pain when you're doing this. One is when you're opening the conj, so when you anesthetize the conjunctiva well. The second is the cautery. When you're applying that, you got to make sure that the surface is very well anesthetized. And the third placement is when you're doing an iridectomy. So you really want to make sure that they have anesthesia inside the eye. I would say most patients are able to tolerate this pretty well. You don't need to put a traction suture because the patients will help you infraduct most of the time and be able to look down. And again, you can not patch these patients afterwards. You can just put a shield on them, especially if they're monocular. They're grateful. Even if the vision is blurred, they're able to see that. Post-op, so intraoperatively, I try to tie the sutures loose, and make sure you have more flow than I usually do. I don't know if any of you use viscoelastic in the anterior chamber while doing TRABs. I never do. But if you do, I don't think we should be doing that in these patients. And try to also not to keep the chamber maintained during surgery. I think that's important. I know some people use anterior chamber maintainers in Europe. I tried, if you make a high enough sclerostomy into the cornea Often you can keep the chamber quite well maintained when you're putting the sutures. If you do a more posterior sclerostomy, the chamber tends to get flatter easier. So sutures are tied loose, have a very tight conjunctival closure. I use a modified Weiss technique to close the fornix space, continuous running mattress suture at the limbus to close the trap. And post-operatively, I again monitor their pressure a few hours after surgery. So I'll operate on these patients early in the morning so that I can see them in the afternoon or evening before they go home and give them a Diamox at night. And most patients do fine. So do I use more mitomycin C to get lower pressures? It varies. In the African-American patients, yes, I tend to use, sometimes 0.4, but my standard dose is 0.3 milligrams per ml of mitomycin C. I think, again, the high-risk patients with Zen available as an option, it's something that I tend to use. The only issue with the Zen is there's a very high rate of needling. So you have to be ready to do that in the office also, and treat these patients. So that's what I have to say about that.
Okay, so this one is the last one now. We will take one more. What kind of tubes is preferable? Do you do a walled tube like Ahmed, or do you prefer a non-walled in such patients?
That's a long answer. So in these severe patients with severe glaucoma, I do either. So I'll give you one scenario. So I'm doing a patient on Wednesday. He's monocular. He has a cataract. He has severe glaucoma. He's deaf. He's 84, and he just got divorced from his wife. So that's another story. So there's a huge compliance issue. I'm not sure if he's going to show back to the office on time. I would not put a Baerwelt in this patient. Okay, this is a patient who has a pressure in 20s, and so this is a patient I'd put an Ahmed in. I've told the patient I think you're still going to be on Diamox post-operatively forever till you're alive, and also on multiple medications. But putting a Baerwelt in a patient like this, where compliance is an issue, is a recipe for disaster. Having said that, most often I'd use a plate with a larger surface area. So something like a 250 Baerwelt. I don't typically like a 350. I know you also have the RD implant available now in India. I think that would be my implant of choice. If I put an implant, I will make sure my preferred way in the post-op period, apart from putting them back on maximal medical therapy and Diamox, is to do a tube fenestration with a vicryl suture. So I use Nino-Vicryl on a TG needle to close the conj after a shunt. I'll use the same needle to create a fenestration, but leave a wick of Vicryl inside the lumen. So it acts like a wick. So I know when my Vicryl opens up in 6 weeks, this Vicryl will also dissolve and close the fenestration. So what's been my impression of this so far? You end up, if you just do that and give them topical medication, the pressure is often in the high teens in these patients, and they meet a post-operative period most often. And so sometimes I'm able to avoid giving them Diamox. And I found it very useful rather than just making punctures of fenestration in the tube. My experience with fenestrations is I cannot predict what's going to happen. Sometimes I'll see a flat chamber. Sometimes I'll see a pressure of 40. I've stopped doing fenestrations, and this single wick technique, I think it's been well published by a couple of people, is my go-to method when I put a large area shunt in these patients.
So we have a lot of questions here, but I don't think we have time for all of them. So okay. I think we should end the session here. It was wonderful of you to come here. So I would just like to thank some people here because of which, we could have this program. So first of all, thanks Centaur Pharma for arranging and giving us a platform for all this discussion. Thanks to Samir and Dinesh for giving us this technical support and making all the arrangements for this. Also, Anil, who has been helping us a lot with this program. We have Dr. Sapna, our anesthetist, Dr. Radhika, who is our medical director, who are always, coordinating things and making things easier for us. My special thanks to you, sir, for joining us here. Being Sunday morning, early 6 o'clock there, it's
an interesting thing. Actually, today's time change, they've gone, Paul fell back 1 hour back. So it was 5 o'clock in the morning, not 6 o'clock.
Deepak, you're looking fresh for 5 o'clock in the morning.
Thanks, Professor.
Yeah, so thanks a lot for coming here and giving us that wonderful talk about about the glaucoma part, which is advanced glaucoma, and giving us all those practical tips here. And last but not the least, thanks Dr. Natarajan. He's always behind us, and he is the driving force, behind all of us. So thanks a lot, all of you, for making.
He's a driving force everywhere.
Yeah. How are you, Deepak?
I'm doing well.
We can see some Chicago through your camera.
I'm freezing here. Okay. It's 1.5 degrees centigrade today in the morning, but this is winter, coming about winter in Chicago. So depressing, but what do you do, right? And you can't even travel now.
I know. And how's the COVID situation in Chicago?
Well, it depends on who you talk to. There are more cases, but the deaths are definitely, and hospitalizations are not that much like they were in the first wave. Right. So in my hospital, we're kind of in the epicenter. We really have only 4 patients in the ICU and with COVID, despite the rates going up. Most that are infected are young people. They're going out for parties still. So at our university for the undergrads, we have mandatory testing twice a week for them. Just saliva test that's FDA approved at UIC. I can go at any time and get a test done, and I've done that several times just to make sure. Very high. And what they've found by contact tracing is basically these young folks, they get together in a bar or a party because they're bored, and that's how they get it. Most of them are asymptomatic; they don't know it, and then they go and visit their parents or their grandmother, and that's when trouble starts.
Right. So how will the saliva testing come to India?
I don't know. It's available. You have to spit a lot, so you have to be careful. So they ask you not to eat anything for 2 hours or feel a little hungry before you go. And so it's a large amount of saliva that you need. I don't know about how it's going to get to India or not get to India. It's an interesting time. I kind of shut myself from the COVID news. There's way too much going on. Right. I guess staying practically careful and being common sense is the way to look at things. But
yeah.
Deepak,
you can stop the sharing the screen so we can see you full screen.
Oh, okay. Let me.
And then in the meantime, Dr. Radhika is requesting the center person to go offline so that we can talk for a few minutes and then you can go. Is it still we are live, Dr. Radhika? So we have to talk. Yeah, we can talk, but we want
my screen is off now, I think.
Yeah, you can see your full screen now. You can see the UI Health Illinois.
I think Dinesh can stop the live telecast.
And the Zoom can be there for a few minutes, Dinesh. Can somebody call Dinesh?
Okay, hold on. Just give me 2 minutes.
Yeah. It was here, I think.
But anyhow, we are talking good for the public only. Nothing. What Deepak?
Yeah,
so how's your schedule as a glaucoma surgeon in Chicago now?
Yeah, we are back to full-time care. We've gone back to what it was, similar to last year.
Okay.
Number of patients and everything else is back to normal. I'm sure you guys are the same.
No, still we are not. Did you?
Not?
No, but what do you
Okay.
do as a routine when you go to the hospital? You have
So-
N95?
Yeah, I don't wear an N95. I use an OR mask. We have a high risk area where patients have tested COVID positive. For that, I wear an N95. In the OR, I don't wear an N95 because all patients are tested right away. They get their test back in 30 minutes. Everybody who, but of course, we have a lot of physicians and nurses and other people there. We don't know their status. So we try to keep doing well. So the test results in the last 90 days, there's been only one person who's tested COVID positive in the OR.
No, but what I'm saying, how do you protect yourself?
I mean, the usual stuff: hand washing, a lot of hand washing. Keep my mask on. If I go into the hospital wards to see a consult, I wear an N95 for sure.
Okay.
In our eye clinics, I don't wear. I wear a mask all the time. I don't wear. I mean, I wear glasses, so I don't have any eye protection. There are some people who still do that. There are other doctors who do wear N95 all the time. So it's variable, but everybody wears a mask. And we also, for patients, we make sure that we've calculated how many patients can be in the waiting area at a time. Otherwise, they sit outside. They don't come into the clinic. We call them and then have them come in. There are no people to accompany them unless, of course, you have, like the patient I talked to you about. He's kind of hard of hearing. He needed somebody for surgical counseling.
Right.
Then we have it. We have special rooms for them, rooms with large lanes, so that they can be 6 feet apart at least.
Okay.
And the usual measures, to clean the rooms and everything else. And so we just finished a study which looking at COVID RNA particles and using the usual cleaning measures in our comprehensive eye clinic, which has all kinds of patients. They're probably the highest risk. So we looked at, we swabbed the slit lamps, the eye, occluders, Humphrey bowls, tonometers, everything else. And I think out of the 200 or 250 samples, we just had one sample that was positive.
Okay.
Over a period of 3 months.
Oh, that's a.
Yeah, but this is using the normal measures of cleaning. What I'm sure you do the same thing for the clinic. So if you look at that, it's very similar to the airline industry, right? I mean, the risk of getting something in the airport or in the airline is extremely low.
Right.
So it's the same thing. And
Right.
But we really don't.
During surgery, do you wear PPE?
I just wear a regular mask.
Okay. No. PPE for the surgery time?
No.
Nothing. Regular gowning.
Just regular gowning. No, regular gowning.
That was my understanding.
All our patients are tested for COVID. So they don't even have to do it 72 hours before because of the in-house testing. Results come back in 30 minutes.
Right.
They just have to come 30 minutes before.
Right.
Yeah. So
I know, but I think even if you're in front of a COVID positive patient, I think if you wear the mask and you wash your hands, I think it's fine, right?
Right. I think you're fine. So it has to be, but there are so many permutations and combinations to the story, right? So I think common sense is the most important thing, right? My daughter is a pediatric infectious disease fellow, and she's the other extreme. So she won't come home. She's in Chicago at Northwestern. So when she comes home, she makes sure that we all decontaminate ourselves, even though we have, and she's also very cautious. But then she works in a very high risk environment. So there's a different story. Yeah.
Yeah. So that's good to know that we're back to normal. So we are still.
Now there are states where they have total disregard to this. So I have a friend who went to North Dakota recently, and he is horrified to see what's happening there. I mean, there's zero anything.
Okay.
And Wisconsin, which is next to us, which is also a very, I don't like to politicize this, but people who are rural, they're very rural and they feel that they're working in open fields and cheese factories, that nothing will happen to them. And so they have this very casual attitude towards this whole issue. So it's tough.
I know, but I think wearing mask and then having the hands washed, I think.
I think that's the best, mask this thing. And if you, for some reason, are in a crowd, make sure you stay away from the crowd.
Right.
And not be close to them. And
Right.
I think you'll be fine. Yeah. So there's
Right.
a lot of hype. I'm sure there's the same thing in India.
But are doctors like you are traveling within the US?
I mean, there's been no need to travel. I honestly have not traveled anywhere. My wife, she's in Florida today because of a family, something going on there. So she was telling me, I mean, the airlines, of course, are not busy at all.
And
And
I believe in India, they're back to normal, I believe.
Is that okay? Back to full capacity? Okay. Have you traveled?
No, I have not traveled.
Yeah.
First time in my life, almost 8 months no travel.
Well, the same thing with me. I mean, the farthest I've gone is probably 100 miles, and that's it.
Okay. That also I have not done.
Yeah. So I got fed up sitting in the house or going back and forth to work, and my wife and I just took the car and just drove to nowhere.
Right. We get a vaccine soon.
The vaccine, yeah, I hope that will come soon. God knows when that will be. I'm waiting for next Tuesday to get over this election nonsense in this country. And hopefully we'll get a clearer picture after that. But, I think it'll be by end of this year. Now, who's going to get it, who's not going to get it is another question, right? And of course, the government has said that everybody who's at risk will get it first, and it's going to be free. So it's going to be a huge demand when it comes in.
I know.
So we don't know. And so I heard there's a couple of vaccines being developed in India also, I understand, right?
I don't know whether it's developed in India, but I think the Serum Institute in Pune is working with the Oxford.
Okay.
And also, I believe once it is proven, US also is going to take a share. So Narendra Modi is trying to make that share who's going to get first and how much Serum Institute can make. I mean, there's a limitation, right? For making
it is. I mean, that India is a huge population. I mean, it's huge.
Yeah.
So, and do you vaccinate everybody? But I think it's going to be high risk and then others afterwards. So,
right. I think they are collecting data from the medical professionals about the medical professionals. So I think we would be the first to get the vaccine.
Next, yeah.
They've already started collecting data.
Collecting data.
Yes.
And that kind of makes sense. And, you do that, then probably the elderly. And I mean, here the rates are very high among the Blacks and Hispanics, extremely high. I think partly is also is the lifestyle, and poverty brings about, you have 5 people living in a 2-bedroom house, so you don't have a choice.
Right.
And the ability to social distance is not good, whether you have PPE available, even if it's a fast. And sometimes it's not just that, it's the attitude, that, okay, well, it's going to be okay.
Right.
Yeah. So, but we'll see, life goes on so far. Definitely different.
And keep us all the time involved in something. We will do something together. I know a lot of things you have suggested, and I'm struggling to get through. But
I should. So we're actually working on, I'm going to start working. We have a huge AI group. I don't know if you ever had a chance to listen to the webinar I sent you the link.
Yes.
Yeah, it was last Saturday. I hope they released the recording because the meeting was outstanding. Actually, it really gave a true perspective, a real world perspective of where this is all heading.
Okay.
And that was the best part about that AI conference.
You can send it to me.
Yeah, they told me they're going to do that because there were some people who did not want to broadcast have their talks recorded. So they're trying to sort that out. But the meeting
Right.
is very, very good.
Are you working on AI?
Well, a little bit. So one of the things, so I spend 1 day of my week at the Veterans Hospital.
Okay.
Half of the patients in that hospital are 10-2 fields.
Oh,
Yeah, very, very severe, horrible glaucoma. The reasons why. So again, as I said, it's hard to figure out progression. Now we have probably about 20,000 of such fields available within the
Right.
system. So we're trying to get together next week with some deep learning experts to see how we can utilize this to feed it into a deep learning network to learn more about these visual fields. So that is the extent of involvement. I think people are looking at different areas now. I think diabetic retinopathy is sort of a beaten dead horse, right? As you know,
yeah.
lots of things have been done.
Right.
People are looking at different other areas. Are you guys still working on AI?
Yeah,
Collaborating with people? Okay.
No, we are working with our own that Remedio offline
Okay.
AI, and we have made a bigger thing, but we got rejected in I think some journals. We are now resubmitting
Okay.
the second part. First was 250 patients we did. Now about 1,300 patients.
Yeah, people are getting more picky now. The journals are getting very picky about AI. So
Yeah, I agree. But we have to compete.
yeah, you
and
have to compete.
grow our
Right?
work. Yeah.
So this company, Remedio, is based in Bombay?
Bangalore.
Bangalore, okay.
And then that Medios company is based in Singapore, but the Remedio guys have taken over.
Okay.
So we are using it for screening.
Are they doing any other applications or just that? Or just for retinopathy?
Radhika? No, is Anand Sivaraman working anything else?
So they're yes, they started working on glaucoma also.
You should discuss with
But I
Deepak.
think what they were. Sorry.
Your voice. No, you should work with Deepak also, I'm saying.
Right. Okay. No, I'll ask him because I think it didn't work out too well. So I think they went back to work on the algorithms. It didn't work out very well.
Glaucoma is tough. You have to ask very specific questions. It's not like diabetic, unlike these retina guys, it's easy. Few dots here, a little bleeding here, a little that there, and you can take a diagnosis. Glaucoma gets a little more tricky.
Okay.
Radhika, what is happening to the live? It's still going on.
Yeah, no, I'm not able to catch him. Or we'll just leave the meeting.
No, but if it is live, if it is live, people will be.
No. We've stopped streaming on Facebook, etc. We've stopped streaming.
But it will be live on what then?
The Centaur platform.
Oh, but you're not able to call Mithali?
No, Mithali is not picking up. We'll just leave the meeting and then I'll keep trying.
Okay. Anyway, thank you, Deepak. Then.
Okay, you're welcome. Thank you, and thanks for inviting me. Enjoyed listening to others.
Thanks for your family time on Sunday.
Thank you so much for getting up so early in the morning for us.
Oh, no worries. I get up early anyway, so that's not a big deal. So
Thanks a lot, sir. Thank you.
You're welcome. Okay.
Thank you, Anupam. Great.
Have a good evening, all of you. Enjoy the rest of your weekend.
And once the recording is ready, Dr. Radhika, you should send it to Dr. Deepak for him to see in the YouTube.
Okay.
Okay, great. Thank you again.
Yeah.
Great. And we keep in touch, Deepak. We will keep
We'll
working.
do that. Absolutely.
Yeah.
Okay. Bye-bye.
And I'm going to be, I know a lot of things I couldn't do, but I will still be perseverant to what to do.
I know you will. Okay.
Yes.
Okay.
Yes.
Bye-bye.
Bye.